My name is Dr. Rodríguez Vega, and I am an intensivist, neurointensivist at IMA San Pablo Caguas in Puerto Rico. I would like to thank Dr. Manu Malbrain for inviting me to participate in this first virtual International Fluid Academy. And I will be talking about resuscitation fluids, 10 papers we should know. I have no conflict of interest regarding this lecture. And we're going to be talking about factors that influence your IV fluids choice, principles of management. We're going to review those 10 papers, and we're going to be drawing some conclusions. When we talk about fluid therapy, there are different factors that affect our choice of fluids. One, we manage intravenous fluids daily, either because it's for resuscitation in the management of shock, for hydration, for treatment of certain conditions, post-op care. Also, we take into consideration the available options we have in our hospital, in our market. By tradition, there are some specialties that are inclined to using crystalloids, and during those crystalloids, some are inclined to using normal salines, others ringers, and others are inclined to use colloids. And also, in a practice that is driven by cost, also that is taken into consideration. What we do know, and we all agree, is that delayed fluid therapy can lead to ischemic injury and irreversible shock with multi-system organ failure. So that is one thing that we cannot do. In principles of management, there are 3 factors that we take into consideration: identifying and treating the etiology. We know there are 4 different types of shock: hypervolemic shock, cardiogenic shock, and distributive shock, and obstructive shock. And depending on those conditions, it's what we're going to be choosing for our fluids. If it's hemorrhagic shock, we're going to be using blood products. Non-hemorrhagic shock, we're going to be considering blood products. Also, if there are electrolytes and acid-based disturbances, those are going to impact our choice of IV fluids. And the way we assess our volume deficit is meaning by invasive or non-invasive criteria. We should all know, and these are tables, we're not going to go into them, but we should all know the composition of our replacement fluids, being crystalloids, colloids, and blood products. I make reference to these 2 tables that might be convenient for you. So this is my list of 10 fluid articles you should know. First thing, our first line of crystalloid solutions. Usually and traditionally, these are our first line because of their ease of accessibility, their cost, they're available everywhere. And one of the studies is the CRISTAL study. And this is a 9-year multi-center open label study, 2,800 patients with hypovolemic shock of any cause. And this was normal saline with versus various types of colloids. And if we can see, there was no difference in mortality with regards to colloids. And but if we look a little bit more into that, even though there was not a statistical significance, there were more ventilator-free days, less need for renal replacement therapy, less development of organ failure when you used colloids. The SAFE study, which was published in 2010, this is about 16 hospitals in Australia and New Zealand, 1,218 patients with severe sepsis, and there was no difference between the albumin or the saline group. There was, in the SAFE study group, there was a published paper in which there was an increased mortality in patients with head trauma. If we look at meta-analysis, they also confirm similar results, either lack of benefit or increased mortality or harm when you're using colloids versus crystalloids. So now, after we choose that crystalloids are going to be our first line of therapy, what are the studies regarding the use of normal saline versus buffered crystalloids? So we have the SPLIT trial. The SPLIT trial is a 2015 study published in JAMA, and this was double-blind, cluster, randomized, double crossover trial of 4 ICUs in New Zealand. This was 22,278 patients, and this was the use of buffered and There was no difference observed between the use of saline or buffered crystalloids. It also did not reduce the risk of acute kidney injury. The SALT study was published in May 2017. It was also a cluster randomized multiple crossover trial, 974 patients in a single ICU in Nashville, Tennessee. And also this was saline versus balanced crystalloids. And if you can see, there was also no difference between mortality and ICU days or development of need for renal replacement therapy or acute kidney injury. The SALT-ED study, this was published in 2018, multi-center crossover, single center multiple crossover, over 13,000 patients and on non-critically ill patients. And if you look at, there was no difference between both groups, between saline or balanced crystalloids. In terms of hospital-free days, major advanced kidney events, there was a favorable outcome between the balanced crystalloids and also odds ratio for acute kidney injury. SMARTS trial, this was a similar study, but in critically ill adults. And these were 7,492 patients. And there was a trend, although not statistically significant, for balanced crystalloids when it was compared with normal saline. 13-day hospital mortality was 10.3 versus 11.1%. And need for renal replacement therapy was 2.5 versus 2.9%. If we look at a Cochrane and a meta-analysis, and this was a Cochrane review over 20,000 patients, and it was also no effect of buffer solutions when compared with normal saline, with reference of preventing in-hospital mortality and the need for renal replacement therapy. So when we talk about colloid solutions as a second line of therapy, they're rarely used as a first line, although some people advocate with regards that there's less volume used, and it might be beneficial in hypovolemic shock secondary to hypoalbuminemia. One thing for certain is that hypertonic starch should be avoided. And this is the VISIP trial. This was a 2008 trial, and in which part of the study was when we were doing the studies with intensive insulin therapy, there was an arm that was using hetastarch. And this study was stopped for safety reasons in terms of hypoglycemic event. But when you look at the analysis, the probability of survivor was lower in patients with hetastarch, and even with between low dose and high dose of hetastarch. So it's not recommended. Same thing happened with the 6S trial and in severe sepsis. And these are patients, it was a multi-center randomized trial, and it was also hetastarch versus ringer lactate, 798 patients, published in 2012. And probability of survival was higher with ringers as opposed to with hetastarch. The same thing with acute kidney injury in times of randomization. It was less risk with ringers. There was other solutions that could be used, and this is what's new. One of the things that could be used is hypertonic saline. It's been used in trauma, and this study is also using hypertonic saline for fluid resuscitation in post-cardiac surgery. The idea of this monocentric double-blind placebo-controlled trial was to see if it reduced the amount of total volume administered on ICU patients, specifically in cardiac surgery patients. This is a total of 101 patients published in June 2020. And it was associated with an increase in urine output, but there was no difference, and it did not reduce the total volume of fluids administered in cardiac surgery patients. So in conclusion, one of the things, balanced solutions are more similar to plasma. It's very important that we all know the composition of the different fluids that we are considering to use. The literature, as we have presented it, suggests towards the use of balanced solutions with, in terms of decrease in renal replacement therapy, vasopressors, and hospital length of stay and ventilator days. But there is no cost effectiveness analysis regarding the use of normal saline versus balanced solutions. One of the things that we know is that normal saline does cause hyperchloremic metabolic acidosis. So when we are evaluating our patients, especially when we're doing large volumes resuscitation, we need to take into account this. Also other conditions, electrolyte disturbances, comorbidities with these patients when we are considering. And one of the things that we need to be cognizant about also is the role of normal saline in patients with cerebral edema, noting that albumin also increases mortality in patients with head trauma. This is it. These are my 10 papers that we should know in terms of IV fluids. And I would like to thank all our healthcare workers. This is my colleagues in the ICU that are working right now, and we're confronting with patients with COVID. Thank you.